And they're already open.
There we go. Okay, so we're starting with our first slide for Potpourri, and you thought LSNA, hyperkeratosis, little bit of interface dermatitis and pigment incontinence, smudging of the papillary dermis. Differential would be superficial biopsy of morphia and radiation dermatitis. You know, the biopsy itself is too superficial to see whether or not there's a lymphoid band. Certainly doesn't look like they're radiation fibroblasts, at least in the portion that we see, but that would be your differential. Let's see where our tissue is way down on one end. Okay, from that power, what do you think it is? With the key being that, and that, and that, and that.
There's like V-shaped.
They're like V-shaped red things.
So probably Verrucous xanthoma.
Probably Verrucous xanthoma. Exactly. So V-shaped red things with some neutrophilic crust. Probably Verrucous xanthoma. V for Verruciform. Very good.
Looks like NF or DF in this power.
NF or DF, which one? Let's scan.
S. I think the color looks more on the tabling. DF.
Okay. But so it's clearly one of the two. Which one does the corneum say it is?
DF.
Okay, why?
Because it's thick.
Exactly. You've lost your reedy pattern, and you have a plate-like acanthosis, which is something that happens with DF but doesn't happen with NF.
Right.
Okay.
Superficial and deep. Looks like it's a April surface. You have a lot of nudes eos. At first thought, I thought it was like a bug bite.
And if it's a bug bite, then what are those guys?
Those look like flame figures.
They look kind of like flame figures.
They're like a well.
Now, do flame figures usually have histiocytes around them?
No.
And yet there are histiocytes around these things that look like flame figures. And that used to be a blood vessel. And there's a lot of red cell extravasation and a lot of eos there. So it would give you something that looks like a flame figure but has histiocytes surrounding it, and you've got a vasculitis with eos. And you got a Pianka, and you just had a heart attack, and Churg-Strauss, correct. So Churg-Strauss, they look like flame figures but have surrounding histiocytes, which are absent in regular old wells. And then you have an eosinophil-rich vasculitis. And then asthma, heart, kidney are the key.
Big specimen here.
So where do you think you are, first off?
Scalp, maybe. All these piloerectors and.
So lots, a normal amount of smooth muscle for scalp, or an awful lot of smooth muscle?
So maybe more genital, probably smooth muscles.
Yeah, anogenital, although the bundles aren't that big in anogenital skin. So where do you have lots of big?
So mucosa, like oil.
Would be striated.
Striated.
So anogenital has lots of smooth muscle, but they're little wisps.
Areola?
You got it. So you know you're on breast,
So there's
right?
like a papillary-
Because it's the only place that you're going to have big. So you haven't even seen the tissue yet, and you know your diagnosis just by sight, because it's what we usually see in that site. And you did get a peek at it earlier, but the often sight is a big clue to diagnosis, and in this case, you have big, fat, smooth muscle bundles. Puts you on breast areola. You have a mammary duct down below, And then you have something, so tell me why this is intraductal papilloma erosive adenomatosis rather than DCIS, ductal carcinoma in situ.
It's the basal membrane, or the myoepithelial layer.
So you have, see this little string of pearls at the periphery, that's the myoepithelial layer? That's intact. That would be intact in DCIS as well, right?
So looking for a tibia, I guess?
Yeah, so you look for atypia, hypercellularity, mitoses. These Roman arch type bridges you can get in DCIS. You can also get as part of the papillomatous structures in intraductal papilloma. My practice is I don't sign these out by myself without a surgical pathologist on it too, because it's sort of where breast meets skin. The recommendation is complete excision for these anyway, because it's unclear whether or not they're a precursor for anything worse, and they certainly can recur and bleed and be problematic. I haven't had anyone disagree with me yet in years of signing them out, but I don't think it's appropriate for me to have my signature alone on that. So teach us, person with surg path background, what else do we need to know about intraductal papilloma versus DCIS?
For me, DCIS actually looks more regular, so you look more for cookie cutter holes as opposed to like those slits and irregular shaped holes in between the cells. Also, when I look at like a papilloma or like usual ductal hyperplasia or florid ductal hyperplasia, the cells kind of in the center kind of have this streaming appearance, whereas in DCIS they pretty much hold their ground and stand their ground, and you can see individual cells. They don't get that streaming appearance.
Okay. So all things that can help. Just in terms of scan appearance, it's been described as looking like an HPAP on the nipple, right? Which is basically what it is, right?
If you're not comfortable signing it out, is it appropriate for our test?
I don't put that portion together, but I
just meant generally speaking.
I would think that in terms of scope of practice, that it is, is probably marginal in terms of scope of practice. But it's one of those things that, things are divided into must have expertise and must have familiarity. This is probably must have familiarity.
Excellent.
First glance at this one, think about Merkel.
Okay, so smudgy, blue cells. Any stains you want?
You start with like a S100, then you can get all the like synaptophysin, chromogranin.
Probably CK20. Yeah. And probably very important one, TTF1, because small cell lung would be the biggest, probably the most important thing in the differential.
It was like a verrucous cyst.
Like a verrucous cyst. Looks like a verruca, but it's cystic. And verrucous cysts often overlap with proliferating pilar or proliferating epidermoid cysts. This has features of both. Lots of squamous eddies, undulating wall in a cyst with verrucous features, and evidence that these are, in fact, papillomavirus infected. It probably starts with papillomavirus infection in a hair follicle or eccrine duct.
It's my turn. In the first impression, it looks just like a superficial provascular, but there is some change in epidermis. And Oh, there's a last. Looks like metastatic melanoma or metastatic.
So if that's within a lymphatic space, it
Yes.
could be metastasis. But you see how there are those little fibers, collagen fibers? That suggests that that is just retraction space and not a vascular space there. So if those are just nevus nests, the nevus could be incidental, but if they're going for a pigmented lesion, how often would the nevus be centered at that portion of the biopsy if you were doing the biopsy? That would be unusual, right? So suggest that what the clinician saw was mainly centered here. So we're going to look in the center and see, so what's in the center? See those gray cells here and these gray cells? And in fact, see how that cell is grayer than the cell above it? In fact, sort of from there to here, and on this piece, from here to there are no keratinocytes. It's completely replaced. That's all melanocytic. You know, not one that really jumps out at you at scan, right? It looks sort of like acanthosis at scan. But those are all melanocytes. So this is melanoma in situ arising in a nevus.
That one little gray cell that's by itself right at the bottom of sort of the fibrosis underneath the MIS.
Okay, you think, let's see.
Would you
Question of whether that's invasive?
Yeah, it looks like it's like halfway in the,
Like this one.
yeah.
Half in the fibrosis, half not. My guess, because there are red fibers on the downside of it, on the underside, I think that connects up. I think that would be very unlikely that that's actually invasive disease. But your scan appearance, you've got intradermal nevus, but it's way to one side. So either it was an incidental finding and not what they were looking for, or you've got gross asymmetry of a lesion that they were sampling. So, that's where you start from scan on that.
Looks like some acantholysis. Say Haley-Haley's would be probably my number one.
So, why are you saying Haley-Haley?
Well, you have acanthosis, and pretty much.
So, when you look at the rings, what's right around the nucleus, are they all red, or do you have some clear spaces?
A little clear space.
Is Haley-Haley allowed to do that? Or does Haley-Haley only know how to make red?
It's usually red.
Yeah. So it tells you it's an acantholytic dyskeratotic, but probably not Haley-Haley. So what else could it be?
So Darier's.
Yeah, Darier's, or if this was a Seb-like lesion, it could be just an acantholytic dyskeratoma. If it were a solitary lesion.
So, our fat looks unhappy. It's more of a chicken soup looking fat.
Yeah. So chicken soup looking fat, suggesting that it is...
Not Ian.
Yeah, that it's not enodosum, that it is not a septal panniculitis, but it's lobular.
So there's a vessel there, but it doesn't look to me like it's a big vessel. It looks normal.
Yeah, there's really not a whole lot of inflammation other than the xanthoma cells.
There's some other membranous change.
There's lipomembranous change, so with all of these large fat vacuoles, granuloma, and lipomembranous change, this is probably lipodermatosclerosis. Very good. The other thing on this slide, see all of these? That comes from being rough with the slides, stacking the slides, and which is why better to take one out at a time and put them back in the box one at a time, so they doesn't take the toll on the cover slips.
Cup-shaped lesion, almost warty.
Cup-shaped, almost warty.
There's some dyskeratosis. I mean, it almost looks like a wart. I don't think it's true warty D. I mean, it looks like a true wart
So
far.
in most warts are keratohyalin granules, let's see if we can get into focus, both blue and red. Usually they just have blue keratohyalin granules. Right? So you've got, and looking at your hyperkeratosis, that is, does it have little holes punched out of it like a wart horn?
It's not perfect for a wart.
Yeah, not perfect for wart. It's a little more compact than a wart usually is.
So it's kind of more like EHK. I think.
Exactly, epidermolytic hyperkeratosis. And so if you have a warty cup-shaped lesion with epidermolytic hyperkeratosis,
like a linear.
so it could be mosaicism, chromosomal mosaicism for bullous congenital ichthyosiform erythroderma, or it could just be an isolated Seb-like lesion, in which case it's an epidermolytic acanthoma. 95% of which occur on the scrotum or labia majora in a woman. So, they tend to be a genital warty lesion, and just like the last one, it's an isolated Seb-like lesion that, if you look for it, has the mutation. It's just sporadic, but it's not post-zygotic somatic, it's not loss of heterozygosity, it's just chance sporadic mutation.
That's not good.
Not good. What flavor of not good?
I'm kind of wondering about Pagets.
Yeah, they are large and gray. They crush a basal layer in areas. They spit out intact, non-keratinized, and they contain pools of mucin. So the pools of mucin, the crushing of the basal layer, the spitting out intact, are the three things that are best to differentiate it from other Pagetoid intraepidermal neoplasms.
Also, kind of looks vascular, like there's like spaces in between those.
Kind of like vascular. Good vascular, bad vascular.
Bad vascular.
What kind of bad vascular?
Maybe like an Angiosarcoma.
Like crack-like spaces throughout the dermis lined by hyperchromatic cells, like real bad vascular angiosarc. Very good.
It looks like a sebaceous lesion.
Yeah, sebaceous lesion.
Has more of a benign feel to it, like a sebaceous adenoma or sebaceoma.
Yeah, like sebaceous adenoma or sebaceoma. Sebaceomas tend to be blue nodules with red ducts. This is better differentiated than that. So, probably in the adenoma spectrum. So marker 4.
Mortuary.
And, our thinking is changing on getting MLH1, MSH2 on these. For a while we were getting it and finding it in much higher frequency than the syndrome exists. And, the problem is it's sort of akin to looking for neurofibromin mutations in a neurofibroma. You're going to find it in almost every neurofibroma. Doesn't mean the patient has neurofibromatosis. It just means, just like a solitary lesion that's like a SEB with EHK. It has the mutations. It's just chance mutation. It doesn't mean you have germline mutation in the syndrome. So, that was has been a definite change in thinking over the years.
This looks monocytic at the top. It's kind of like two populations.
Yeah, like two populations, and the ones below look like...
Those look more either spindly or even like neural looking cells.
Mast cells, jumping dolphin, sinusoidal curved wavy spindle cells. So it looks like a neurofibroma below and a nevus above. So is Occam's razor intact, or did Occam go on vacation?
I mean, I don't know if I have all the info for all that, but I would say it's more likely that they're just two different looks of melanocytes.
Yeah, exactly. So it's probably all one lesion, especially given that it's patchy and sort of nested even in the part that looks neural. So it's probably just neurotized nevus. Great. Really mimicking neurofibroma. Like a clear cell acanthoma. Very good. So you always have a neutrophilic crust above. So verruciform xanthoma and clear cell acanthoma always have a neutrophilic crust, and then the clear cell acanthoma has the abrupt cutoff from the paler cells to the less glycogenated cells.
Punch biopsy here, so there's something going on in the fat.
And what portion of the fat?
I mean, it could have been a septum that's all thickened now.
Yeah, so there's a septum that is definitely, big, fat collagen bundles like that don't belong in a septum, right? So this is a big, thick, wide, fibrotic septum that still has some granuloma in it, so probably...
I mean, it could be old EN, like a Meischer or whatever, Meischer's.
Yeah, so it probably is just old erythema nodosum, where you still have some granuloma. The acute stage of EN is widening of the septum with neutrophils. Then lymphocytes and granulomatous inflammation move in, and the late stage is fibrosis and granuloma. Very good.
Almost like fibrosis around these blue nodules.
So blue nodules with fibrosis. So blue nodules, and can you make out a little bit of the wall of the duct? What color is the wall of the duct? Right at the edge there.
Looks like pink red, I think.
Yeah, pink red. So what's a blue nodule with big red ducts?
Blue nodule, big red ducts. Adenoma would be black and dark blue, or black and copper. It doesn't look like that.
And then you got these clear cells with scalloped nuclei, bubbly.
It's just running sebaceous again.
Yeah, sebaceous. So blue nodule, big red ducts in the sebaceous spectrum. Anyone want to jump in? Sebaceoma. And then this sebaceoma, I'm just looking at the background here. You got a lot of other sebaceous here, some little pilar germs. I'd wonder if this sebaceoma arose on a background of organoid nevus. Okay, Rob.
Broad shave.
Broad shave. So if you were a clinician,
They were probably thinking melanocytic.
Melanocytic, or do you see anything that looks melanocytic, and are we on sun damaged skin? So what else would you be thinking on non-sun damaged skin, like trunk, proximal extremity, bathing suit area, where you'd be taking a broad shave. Anyone? Where? Yeah, MF question, right? So sun damaged skin, broad shave, you're probably looking for Lentigum maligna. Non-sun damaged skin, broad shave, you could be looking for melanocytic or you could be looking for MF, right? And then what at scan either is or isn't good for MF? How would you describe your corneum?
Pretty unremarkable. I mean, it's like a ortho.
Yeah, kind of regular orthokeratotic, and then how about the lower bit of it?
Compact red.
Compact red. So it's normal above compact red. Is that what you see in MF?
Like tinea.
That's tinea. So they were looking for MF and they found tinea, right? All at scan, because it's a big, broad shave, non-sun damaged skin, inflammatory. So they were probably looking for MF, something red and scaly. And the horn of MF is uniform because it's a chronic, stable condition. The horn like this, that's normal basket weave on top of compact red, is typical for tinea. You nailed it. Good for you. Well done.
There you go, right.
It's a Manning, looks like a Manning squamous, and I'm wondering it's a AK or.
I think you're thinking the right thing. You just have the letters in reverse order. So glassy, neutrophil microabscesses. So you said AK, but you meant KA. Keratoacanthoma. So glassy, atypical epithelium, pushing into the dermis, usually eosinophils present, usually elastic trapping present, neutrophil microabscesses common, hypergranulosis in vertical squamous aggregates in the center of the lesion, because this expands out from hair follicles. So this is the residuum. See all of these vertical things in the center? Those are the residuum of those hair follicles that have exploded to become the Ka, and you still have the hypergranulosis. Squames have hypergranulosis at the edges, but not in the heart, not in the center of the lesion. It's a tongue twister, but helpful. Okay, next one.
Looks like a big pink ball with vessels.
Big pink ball with vessel. Where does the vessel wall end?
Hard to tell.
Hard to tell. So this is or it doesn't end.
Angiolama.
An angiolymyoma. The ball is the vessel wall that never ends, right? So angiolymyoma, well done.
I'm wondering if they're looking for temporal arteritis.
They probably were, and did they find it?
They did.
They did. So temporal arteritis is giant cell arteritis. If there are no giant cells, there is no giant cell arteritis.
A helpful name.
It is, in fact. But temporal arteritis is not as helpful because it doesn't bring your attention to the giant cells, which must be present. Right?
So there's certainly giant cells here. Some look a little osteoclast-like. Could be giant cell tumor tendon sheath.
So it is a large, oval, collagen-producing tumor with osteoclast-like giant cells and gray, round fibroblast nuclei. So yes, it is giant cell tumor of tendon sheath. That's a great, in my opinion, resident slide. The great fellow slide would be the exact same slide with not a single giant cell in sight, right? Where it's fibroma of tendon sheath, but equally recognizable because it's a big oval mass of cells forming ropey collagen and uniform gray, round, plump fibroblast nuclei.
I also find it useful that there's some areas of like xanthoma-like change here and there sprinkled.
And that's really common. The xanthoma-like change and the hemosiderin both can be helpful, that it tends to become pigmented over time.
That's bothersome. Now the question is, what type of bothersome?
Okay, so what type of
Oh, it's
bothersome?
melanoma.
It's melanoma. You know, the big masses of pigment in there helping. But, you know, you have masses, they certainly are not maturing or dispersing. You know, big masses, lymphoid aggregates, pigment. We don't see much of anything at the junction.
There's a little bit. But
Little
I'd
bit.
still be worried that it's a met.
Yeah, I agree with you. That is more likely metastasis than primary.
Melanocytes there.
There are melanocytes.
First, like they sort of look like they were hanging like banana shaped, like a little spits, but
Like a little spits, and there certainly is hyperkeratosis, which you can see over a spits, right? What if this were an acral lesion, and that's acral hyperkeratosis?
well, if there's just that little Pagetoid spread, I guess it's okay.
So a little Pagetoid scatter is fine in acral lesions. Is it fine that that nest isn't really at the tip or side of Reedy?
No, it's not.
Is it fine that your dendrites are asymmetrical in shape and size?
It's
And that your nuclei are a little large, a little angulated? This is really subtle, but you know, this is a bit of an acral melanoma. And the problem is the sample they gave you, and in history, if they told you this was piece of a 5 centimeter thing, you'd probably get it right. If they didn't tell you that, you know, it would be very, very, very easy. Just like the 2 cases we discussed this morning where history was misleading, and it is so easy to go down the wrong path.
So there's necrosis, but I don't know if it's full thickness. I think there's reepithelialization.
Yeah, exactly. There's reepithelialization. Very good. So you had full thickness necrosis. Now there's reepithelialization. So what's your differential?
Probably either be EM, TN.
Yeah, like old EM, TEN absolutely would probably be at the top of your list. Let's look a little bit higher.
There could be like herpetic change.
Exactly. This is an old herpetic blister. You can see the remnants of the shadows of multiple nuclei. So there was multinucleation and some ballooning change. So this is an old herpetic blister healing. Well done, sir. And can you hear them crunching in my hand? That's like the worst possible thing you can do to the cover slip. So I got to put it down.
So this is fat with looks like inflammation.
Yeah. So fat with inflammation, and what's this capsule doing around it?
I mean, it is there. I'm not sure what it's doing.
It is there. So, you know, if this is just localized fat necrosis. But does localized fat necrosis, first off, there's not a whole lot of necrosis, right? And what's all that mucin doing? There's a little septi there. So what else could be an encapsulated mucinous?
Like a spindle cell?
Yeah, like a little early spindle cell lipoma is probably exactly what that represents.
So you have some thickened collagen here. It looks like there's Oh, scabies.
Exactly. Exactly. So, there are always going to be red herrings on the slide, right? Other things that draw your attention. And if you're struggling even for a minute, just go very quickly top down.
Let's see. So these are like palisaded. It's only palisading granuloma around possibly some sort of organism. This could be globi surgery, or it could be way off.
Okay, so
kind of. Oh, is that a splinter?
So it's long, and then it's round.
Okay, so that's just a cross section of a splinter or a suture.
Suture
granuloma.
Yeah, what you're looking at is a knot, right? Which is why it's coming in all different directions. So braided suture granuloma. But everything you mentioned, you just crafted a wonderful question because you provided all the distractors that, might be plausible other things, right? I see a great future ahead of you as a question writer.
It looks like we have some superficial vascular spaces that are dilated.
Yeah, it kind of resembles what?
It looks like lymphangioma.
Yeah, it looks like lymphangioma, right? Do you normally get this deep a biopsy on a lymphangioma?
No, I think, no. I imagine they were more concerned about like an Angiosarcoma.
And what's this brown stuff down here?
It's like pigment, hemosiderin.
Yeah, like hemosiderin. So what would give you a superficial thing that's like a lymphangioma and then deep hemosiderin?
Like a Pagetoid.
Like a Pagetoid hemosiderotic hemangioma. Absolutely. Well done.
Looks like we got a pretty dense infiltrate, binding collagen spaces.
That's not in focus on that, I think. Sorry. Okay, go ahead.
I would say it's kind of it's a really dense infiltrate binding collagen spaces. Trying to see what the cells are. Pretty irregular and probably.
Are they round
Kind of
or do
binding.
they flatten off and show nuclear molding?
Yeah, they flatten off and show nuclear molding, so maybe it could be something metastatic.
And are they all in large aggregates, or do they have some tendency to go single file?
Single file.
So what are these things with a little red rim, pink rim, nuclear molding, single file?
I mean, something metastatic is what I would think, like breast. Or
Anyone want to jump in? Other thoughts?
Leukemia.
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 Yeah.
Oh, there is some organism in the sternum. Some worms.
You can see the little spine on her back, right? So she has red spines all along her back. And so, anyone? Scabies.
Yeah, we had a good cut to the chest. Thorax.
So, she's just trying to take care of her family, and someone comes in, and it really is. It's like, the other version of Star Wars, where you have all of these workers trying to take care of their families, thinking they got a good government job, building the Death Star, and
So I see giant cells kind of palisading around something.
yeah, so giant cells palisading around something, and what are those things there?
Are those little
Probably hairs.
something formed by? Yeah.
All right, so this is just granulomatous folliculitis. So granulomatous folliculitis in what?
Something melanocytic.
Yeah.
Amoeba.
Yeah, nevus. So this is a nevus that changed, and it changed because there was a granulomatous folliculitis. So, you know, the good way for a nevus to change.
It looks like there, in the first cut, there was some acantholysis, but
Yes, it definitely looks like there's some acantholysis. And
there,
what color around the...
it's pink, but it also has a little bit of white. I'm looking for-
Yeah, and up here you've got some greens, some corons.
So I want to know history, you know, if the person has Dariers or if this person
Yeah,
has
exactly. And in
isolated
fact,
lesion.
all of these little aggregates of blue, those are all early corons. So, you know, this is either Grover's in a seb, or it's a type, or it's a solitary acantholytic dyskeratoma, or it's someone who's got a seb and has Dariers. Let's see if we can make out the history. Well, it says Seb, and then it says Haley, but it looks more like a Dariers pattern than Haley on path. Given that you have true corons and white circles as well as the other.
Well, ciliary elastosis, pigmented skin. There's some vessels there.
And are the vessels big or are they little?
No, they're pretty small, almost like a microvenular hemangioma.
That's exactly what it is. A little microvenular hemangioma on sun damaged skin.
What about that? What is that entity called? Basically little angiomas and a lot of sun damage.
Well, there's elastotic.
Yeah, how are those different?
It's the same.
Okay.
It's the same thing.
So I'm more in the pilar tumor than basal cell, based on the stroma.
So the stroma is more myxoid.
Do you think it's more mixed? I thought it was more pink.
So you thought more pink.
I thought more pink.
Okay. So
I was more, I mean, it could, I don't
so
know
you
that I
have pink
see.
strands, blue buds, and horn cysts. So what's your differential?
So infundibular cystic basal. And,
Exactly.
like, you know, trichofolliculoma.
Or BFH, basaloid follicular hamartoma. So pink strands, blue buds, horn cysts is either going to be infundibular cystic BCC or basaloid follicular hamartoma. Basaloid follicular hamartoma is often autosomal dominant, multiple papules, can be Blaschkoid if it's loss of heterozygosity. And this was a solitary bump on an old man's nose.
Oh, then I'd probably be more concerned about basal.
Yeah. And they really are dead ringers for one another. So without history and demographics, you're not going to get it right.
That looks like a papule that's full of vessels, maybe
Yeah.
a PG.
Yeah, sort of like a PG. They're certainly dilated vessels, and they're actually, the walls are a little bit thick and hyalinized. So this is more like an old cherry angioma than a PG.
The same bug. Is this the deja vu?
Actually, this does look like the same family we saw before, the same family portrait.
This looks like Merkel.
Looks Merkel-y, and that's exactly what this one was Merkel. Big, gray, smudgy, salt and pepper nuclei.
interphase.
How long has the condition been going on?
Not very.
Not very,
Normally.
because you have, just a little bit of red. If it's half and half, it's about a week. Most of this is probably even less than a week, right?
Mm-hmm. I mean, it's sort of wedge-shaped. I don't see extravasated reds, but it kind of reminds me of Cleva a little bit.
So you said you said the words, I don't see
except for all
extravasated reds,
They
except
don't-
for all the red stuff.
They're all kind of coalescing.
Yeah, exactly.
There's not like little
Co-
spots,
but that's
so-
that's an important point. Your eye didn't pick them out as erythrocytes just because they were so confluent,
Mhm.
right? So interphase dermatitis, lymph in every hole, a fairly acute horn, wedge-shaped, superficial and deep, lots of red cell extravasation. And I agree with you, pityriasis lichenoides is by far the most likely diagnosis. So concerned with melanoma because you have irregular nesting pattern, irregularly shaped nests at the DE junction. Tell me about the dermis.
It's very fibrotic, so
Very fibrotic with lymphoid aggregates.
so probably there might be a desmoplastic.
This is desmoplastic melanoma arising in lentigo maligna. Very good. You're absolutely correct.
So that's pink nodule in the dermis. These some of these are squamous pearls or more sweaty.
So that's the question. Sweat or pilar? It's fairly deep in the dermis. It's composed of these, very round to oval.
Yeah, the first blush looks like a trichoadenoma.
Like a trichoadenoma. Exactly. Eyeglasses, red Cheerios filled with keratin.
So deep there.
Yeah. It's a deep trichoadenoma.
Depends if it's on the surface or deep.
So this
Seems to
is
be
deep.
Phase.
So this is deep, I would think.
So I'd favor more of an HPAP then.
Like an HPAP. But this is from a nipple.
And flashback to before, like an introductal type
But
of lymph
this is from a finger. I'm such a liar. This is from a finger.
This is the papillary digital.
Probably more, that one, if it's from the digit and it looks like an HPAP, look awfully carefully because it's probably an aggressive digital adenocarcinoma. And this one was actually from the vulva and was an HPAP, just like you said.
So would you have to do site or would you?
Site and history is kind of critical for that because you're only seeing a piece of it. You couldn't even see if it was circumscribed, right? And there's some solidy areas, so you really want history on that. And I don't think it would really be fair without, quite honestly.
So it looks like lots of those nudes maybe deep in.
And lots of nudes, and what's here?
So kind of like feathery. Is that a Ursi kind of viral chain out?
So, anyone, what do you think?
Coxy or crypto?
Coxy or crypto, but look back. You've got pus, and these are grains. It's a mycetoma.
Madura foot.
Actually, this one was not Madura foot. This was no. I mean that is a synonym for it, but this one is actually M. canis head. This is an M. canis mycetoma on the scalp. Thought to be a pediatric sarcoma. It was like a 20-pound thing in this kid's head.
It's like a carrion.
It was
Makes
big.
sense.
Well, it's like carrion gone bad, right?
You scraped off my stomach, David.
The main change is the superficial infiltrate with dense infiltrate and many cells looks like histiocytes or melanocytic cells.
Or so you think histiocyte or melanocytic.
Yes, so
If these gray things are melanocytic and you have these black cells all through it as a band, then this is
I wonder is MM
or anyone else thought for the halo nevus.
halo nevus.
So in melanoma, the black lymphocytes would tend to be at the periphery and underneath. And in halo nevus, it's friendly, so they're all through the lesion, mingling.
Yes, I got you.
Looks like some necrosis of the epidermis.
And what else is necrotic?
I'm not sure exactly what that is.
If this was vertical and extended to there,
Hair follicle.
hair follicle, what gives you sebaceous or hair follicle necrosis?
Herpes.
Herpes. And then do you see any ballooning degeneration in the epidermis? So, nailed it. Well done. Herpes or zoster. So any herpetic.
This one to me, the collagen stroma looks like it has more of a kind of bluish color to it.
Okay, agree. Which could be myxoid or could just be sun damage.
Yeah. And then I want to know where it was from, I guess.
Arm. I just made it up, but arm.
So it has kind of a pseudoperiomatous hyperplasia type look to the epidermis.
Sort of like PEH. Multiple hair follicles starting to open. Trapping of elastic. Hypergranulosis
So I
in the
guess
center.
it's probably maybe early KA.
That's exactly what it is early keratoacanthoma. When it's, just getting ready to explode. So it was handled like an alopecia biopsy, right?
So there's some alternating para, looks like, in the surrounding corneum. It doesn't look like a scarring alopecia. That's the obvious lymphoid tracts.
Why is your papillodermis all the way down to here? Fibrotic, full of little vessels. So this is all angiofibroplasia down to there. And why is your granular dead and red up there?
Scratching.
Yeah, exactly. This whole thing is just LSC on a scalp. So prurigo nodule on the scalp, or like in simplex chronicus on the scalp with the altered corneum. All of this death of the granular is fingernail work.
What's that stuff in the actual follicular Elston, like the junk in there? Is that just...
Oh, like that? Yeah. Debris, keratin.
Okay, so that's the one we're seeing.
Yeah, so that's like keratin debris and bacteria.
Okay.
But your point would be look for tinea, look for things like that in there. But all of this death here, this red death, if you want to know what death looks like, it's red. Right? It's eosinophilic. So that's all fingernail work there, which is a clue. Okay, that's it. We're out of time.
Thank you.
Thanks very much.